Good morning, everybody. As you know, my name is Julie, and today I'll be presenting a pilot study on the use of a new virtual nursing care delivery method that our team of investigators are currently completing. Our research team is led by two nurse scientists, myself and Dr. Burkhoff, who are both in Christiana Care's Research and Evidence-Based Practice Department, and Dr. Alicia Salvatore from the Value Institute, who is an expert in public health, and along with our very large home health care nursing staff team. We are the recipients of the Quick Step Rapid Science Grant, which is a one-step funding. Funding supports our pilot study, facilitators and challenges, and the adoption of a virtual nurse visit in the home health setting, and our study team has no conflicts of interest to disclose. Since the COVID-19 pandemic started, nearly 400 home care visits were missed at Christiana Care Home Health because of patients' refusal to have home health care nurses enter the home, which was primarily due to fears around COVID-19. So to ensure the continuity of high quality care during a pandemic crisis and to also reduce exposures and possible transmission, Christiana Care Home Health developed and adopted a newly conceptualized virtual nurse visit that we often call the VNV, which is now embedded into our at-risk heart failure patients' plan of care. The virtual nurse visit is a nurse-led telehealth visit that consists of a brief synchronous meeting using Zoom video technology. During the visit, a home health nurse and the patient will sit and discuss their current state of health, look at symptom management, and also work on patient education. The VNV is new and it's innovative for home care and nurses to interact with patients. However, much is still unknown about a patient's ability and willingness to adopt a new care delivery method. So the purpose then of this study was to explore facilitators and challenges that high-risk heart failure patients have when adopting a virtual nurse visit. This is a pilot study using a mixed method convergent parallel design that's designed to assess and describe the complexity and the contextual factors associated with adopting a new technology. Coupling quantitative and qualitative data can illuminate multifaceted phenomena that are not typically captured during a single approach, and it's particularly relevant, for this type of study when we're exploring both quant and qualitative aspects of patient acceptability and satisfaction with the new technology. So as you see, the variables here are independent variables focused on exposure, and dependent is based on assessment. And then our measurements, study measures consisted of demographic data that was obtained through several sources of home health care patient data sets. The SUS survey tool is a reliable tool for measuring usability of a wide variety of products and services. And then we also used a set of semi-structured interview questions that focus on user experience and satisfaction. The sample consisted of at-risk for hospitalization heart failure patients who were receiving VNVs through the Christiana Care Home Health Network. The setting was in either the patient's home or assisted living. And then you see the various criteria here. One thing I did want to point out specifically is that all of the interviews did occur during the third virtual nursing visit so that patients had enough time to really acclimate to using a new technology like this. So for our results, we had 34 participants, and the mean average was 75 years. Most were female at 53%, and we had males at 47%, which was great. We were nearly 50-50 in gender. For race, 79% were white, 21% were black, and we had no other race represented. As far as living arrangements go, most patients were living at home, and all were living at home. We had no patients living in assisted living. Excuse me. So 79% were at home, and somebody was living with them. For marital status, 41% were married, 32% were widowed, 44% had a high school graduation, while 35% had some college. And then I'm going to move on to qualitative findings because we're still analyzing our demographic and our SUS data. Our four initial themes are perceived safety, user experience, delivery preference, and satisfaction. And I'm going to talk a little bit more about that in the discussion, which is completely based off of just the qualitative results at this point. So our patients encountered some technology challenges as expected. Most were related to difficulties setting up the virtual visits. In those situations, a caregiver, which was usually the daughter for our sample, needed to be present to initiate the session. Patients also commented on the difficulty with linkage and asked for an easier connectivity method and suggested sending a link via email or text message rather than sending them passwords or numbers that they had to input to access their virtual visit. So some were willing to participate in V&Vs out of necessity, which we expected. But they also said that they still prefer the nurse to be face-to-face and would like to continue using this method as a supplement rather than a replacement to face-to-face or in-home nursing care. The patient experience was certainly enhanced by using this method, which primarily relates to the convenience of the virtual visit. Patients didn't have to leave their house, they didn't have to get out of bed, they didn't have to get dressed, which was a big plus for some of them. It saves them time and sometimes, in some cases, money because they didn't have to arrange for transportation. If they had a caregiver at home who was working virtually, they didn't have to miss work to set them up in the Zoom session. But interestingly, patients perceived an increased length of visit during virtual visits, but there's no time difference between in-home and virtual visits. We think this occurred because the virtual visits were very focused on specific items such as signs and symptoms of disease management, and also education, rather than the nurse trying to complete everything all at once while they were in the home. And lastly, patients enjoyed having the same nurse at each virtual nursing visit. The consistency increased trust and rapport, and it provided the ability to build upon previous visits and education. And as far as our limitations, we used the convenience sample. It could create selection bias because maybe certain people wanted to participate. Patients were of advanced age and they had specific needs related to video conferencing. And lastly, data collection occurred during the summer. So some of the fears may have decreased at this point in comparison to what was occurring from March to June. And then we just want to say a quick special thanks to all of our funders and to Excel, to NIH, Value Institute, Embry, and especially Christiana Care Home Health Team, who has done tremendous work with this pilot study. And I'd just like to open up for any questions.